Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Inside the Issue. As today we talk about the integration of bispecific antibodies into the management of multiple myeloma. We have a great faculty today to discuss this exciting topic. Dr. Hans Lee from the MD Anderson Cancer Center in Houston, and Dr. Saad Usmani from the Memorial Sloan Kettering Cancer Center in New York. We have some additional investigator faculty who participated in a survey that we'll show you later. As always, if you have any questions or cases you'd like to run by us, just type them into the chat room. We'll talk about as many of these as we have time. As always, we have a 1-minute pre and post survey for you to take. If you take that, you'll get a little more out of the meeting and we'll learn a little bit about you. We do webinars all the time. On Thursday, we're going to talk about ER-positive metastatic breast cancer, a really hot topic at the recent ASCO meeting. And then next week, on Tuesday, we'll continue our Meet the Professor series on soft tissue sarcoma. And also, we're going to do a review of recent data sets in hepatocellular cancer on Thursday of next week. We'll be coming back talking about a really hot topic in oncology, hormone-sensitive non-metastatic prostate cancer, including the big EMBARK study on July the 31st. And well, bispecifics is hot in a lot of ways. We have another program coming up on bispecific antibodies in non-Hodgkin lymphoma, and we can contrast what we hear tonight to what we hear for that program. And then on August 8th, we have a program on metastatic pancreatic cancer, talking about some interesting new data sets from ASCO. We know a lot of people end up listening to replays of our webinars. If you're into podcasts, check out our Oncology Today series, including a recent program with Dr. Laubach on myeloma. But today, this is part of our Inside the Issue series. And as I do with all of these series, I met with each of the faculty actually this past week to record an in-depth presentation going through a bunch of papers and new trials. And the idea is to check out those two, and then we'll see what we talk. We're in the webinar here. We're going to try to take things to the next level. But these two fantastic presentations go through a lot of new data sets. And also, both of the faculty present some great cases, and we're going to try to talk about a few of those later on in this conference. Here's where we're heading today. We're going to start out talking a little bit about sort of the biology and pharmacology of immunotherapy and myeloma. Then we'll look at some of the new data sets, although, again, you want to really get a look into it, check out the presentations. Then we're going to show you a survey we did of the faculty, including these additional investigators, about what they usually do in their practice. And then we'll finish up looking at new trials, combinations in particular, even combinations of bispecifics. And if we have time, we'll get into a few of the cases that are presented. But Hans, I just want to start out and just kind of get everybody on the same page about how these therapies work. And maybe you can comment a little bit about what BCMA is and why it is that it's being targeted, not only with bispecifics, but also CAR T.
Yeah, thanks, Neil, for having me on the program today. And it's really great to be here and talk with Saad and you about bispecific. So BCMA stands for B-cell maturation antigen and really emerged as an important target in multiple myeloma over the last 5 to 10 years. Has been clinically validated in both CAR T, bispecifics, and other immunotherapies. I think what makes BCMA a particularly good target in multiple myeloma is that it's relatively exclusively expressed on mature B lymphocytes, particularly plasma cells, little expression on other hematopoietic tissue and non-hematopoietic tissue. And it also has biological relevance as well. So basically upon binding, most commonly by APRIL, to lesser extent BAFF, basically this activates a cascade of signals that leads to the growth and survival of long-lived plasma cells. So not only is it just an antigen target that's expressed on myeloma cells, but if you inhibit or if you target BCMA, it also leads to the suppressed growth of plasma cells as well.
So Saad, a quick question from the chat room. Actually, we're going to get into some of this with the survey, but the question is, would you use a BCMA bispecific? Ask for somebody who had a prior CAR T therapy, BCMA CAR T therapy, and if you did, would you lean towards using, if you could, a non-BCMA bispecific?
The answer is it depends. I'm comfortable using bispecifics in a post-BCMA CAR T patient. If the relapse occurred more than 6 months after the BCMA CAR, where, the relapse may be a result of, the CAR T cells not persisting, I would be okay with using the BCMA bispecific because BCMA is not an antigen that myeloma cells lose. It's more, from an evolutionary standpoint, something that stays with the vast majority of patients. Mutation or downregulation is not something known as, a common way of resistance. However, if the relapse is less than 6 months or so, I would rather utilize a non-BCMA, target for that kind of patient if they did not have, a good response or progress through within the first few months of a BCMA CAR.
Interesting. So, Saad, just to continue our look at sort of the biology of what's going on, can you kind of explain what a bispecific antibody actually is, and kind of from the point of view of a molecular point of view, how it differs in terms compared to, say, CAR T therapy?
So it's the poor man's CAR T, in some ways. So, I think the idea of the bispecific antibody, or the bispecific construct is that one part of that construct recognizes a surface antigen that's commonly expressed on the cancer cell, and the other one can be targeted to any innate immune cell. In this case, it's the T cell, which is the target we use is CD3, and we can use BCMA or GPRC5D or FcRH5 for myeloma. Those are the three antigens or surface antigens that have been examined in myeloma so far. BCMA is the one that's there from the very beginning and responsible for the maturation and proliferation of mature B cells and plasma cells.
So, Hans, it's interesting that there's some non-BCMA targets as well. First, GPRC5D. Can you explain what that is and why it's being targeted?
Yeah, so GPRC5D has emerged as an important target in myeloma over the last 5 to 7 years, largely from work done by Eric Smith when he was at Sloan Kettering through some profiling studies. And so, this is also nearly exclusively expressed on plasma cells or myeloma cells. But there is some other expression of GPRC5D on hair follicles and keratinized tissue, which may explain some of the on-target, off-tumor adverse events seen with GPRC5D targeted therapies. One thing that's different about GPRC5D compared to BCMA is that there's no known extracellular peptide shed by the myeloma cells of GPRC5D. So one concern with BCMA is that there's something called soluble BCMA, which can act as an antigen sink with BCMA targeted therapies, but that does not seem to be the case with GPRC5D.
So we'll get into this later if we get to the cases, but Saad, maybe you can just comment on some of the sort of off-target or I guess on-target effects that affect other tissues, and clinically what kind of side effects you see with these agents.
So I think, with BCMA, it's mostly, the immune system cells that actually express BCMA. So, primarily B cells and plasma cells that we're really worried about. So it's really the infection risk that ends up, being, the common one. With GPRC5D, however, skin and nail changes as well as taste and weight, issues are a key concern. So GPRC5D is, expressed in the skin and nail bed as well as, in the mucosal membrane, and that's where, the issues arise.
So, Hans, you also talked about FCRH5. They have to come up with some better nicknames for these generic names. But anyhow, can you explain what FCR, I'll call it FCR just for short, what that target is and what we know about bispecifics, and also this issue of sort of on-target toxicity?
Yeah, so FCHR5 also highly expressed on plasma cells and myeloma cells, and so has emerged as an important target, primarily in the form of cevostamab, which is a FCHR5 targeting bispecific. And there has been other trials looking at FCHR5 targeting immunotherapy constructs such as an ADC, which did not show actually much efficacy in the past. So I think it seems like relatively a clean target, but we're still learning a lot more about FCHR5 through the cevostamab trials in terms of other potential adverse events. But it's a good target because it's again expressed primarily on plasma cells and myeloma cells.
So before we look at specific data sets, maybe just to take a little of a broad view. So this Saad is I guess a summary of the available or the BCMA bispecifics currently under study. The two in gray are no longer being evaluated. Any broad perspective you want to provide, Saad, on these agents, the differences between them that, from your point of view, are important?
I think that one of the key, differences is in the route of administration as well as frequency, and that speaks to the differences in those constructs and their half-lives. So that's the most important, difference we see, and I think this will be clinically relevant. The other thing that I find, very interesting is the response rates are somewhat similar, with each of these constructs. So is, for the most part, the CRS rates and the low neurotoxicity signal. Each of these are, small data subsets. So, it's hard to compare them, amongst each other. But, I think, the linvoseltamab construct may actually have, it appears to have lower, overall CRS rates compared to the others.
So Hans, Jack in the chat room wants to know about bispecific T-cell engagers and whether they're more effective than bispecific antibodies. What is a bispecific T-cell engager, Hans?
Yeah, so bispecific T-cell engager, I think, are used interchangeably with bispecific T-cell antibody. Is bispecific T-cell engager, otherwise known as a BiTE, is a trademark term by Amgen. So AMG 420, for instance, or AMG 701 were both BCMA BiTEs, again, trademarked. And so I think we typically use these terms interchangeably, whether they're engager or an antibody.
So, okay, that's very helpful. Again, this is sort of an overview. We talked before about non-BCMA. Saad, anything you want to add to what we said before? Again, kind of contrasting these various agents, none of which are currently available, and also your thoughts on which one is likely to become available in the immediate future.
I think in the immediate future, we'll probably hear about talquetamab, potentially getting a regulatory nod, in the US and Europe. That's the farthest along, essentially. It is a subcutaneous formulation, and the dosing is different for the every week or every other week. The responses were quite impressive. However, this is where you see the skin issues. The second construct, that is currently in clinical trials, a little behind talquetamab, that looks a little bit interesting, and I'm wondering, whether, given the fact that that construct actually has two binding domains for GPRC5D, that we might actually see a deeper response and maybe can play around with the schedule a little bit more to give it less frequently to patients.
So Hans, we talked about the nail and skin issues, but also, I guess, GI problems, dysgeusia, which we're seeing with talquetamab, and I think we have that in one of the cases. But I'm curious about your experience with dysgeusia, when you see it, what other kind of GI issues you see, Hans?
Yeah, so we actually were not involved with any of the talquetamab clinical trials at MD Anderson, so it's only available on clinical trials. But typically it's seen, as people continue to get dosing, 2 to 3 months, 4 months into getting the the GPRC5D targeting therapies, and typically it's managed by dose delays or reductions in the frequency of dosing. And for instance, the hand-foot toxicities can be managed by steroid creams, moisturizers, and things like that. And so it does seem to be dose dependent and dose frequency dependent as well.
So Saad Hassan in the chat room wants to know, can you comment on, is there such a thing as CAR T directed against non-BCMA and also allo CAR T?
So we do have GPRC5D directed CAR Ts in clinical trials, and the first homegrown GPRC5D CAR, again, that was developed by Eric Smith here at MSK, and the trial was published in the New England Journal of Medicine last year, with my colleague Shamil and Cody being the first author. And that construct is now being further developed in trials by BMS. So we saw some early data at ASH and ASCO around that experience, and the data looks very impressive, with the overall response rates, all patients responding in the relapse refractory setting. And then we do have allo CAR constructs with targeting BCMA. So we don't have any non-BCMA targeting allo CARs. But we haven't seen any updated information about that construct in about a year or so. And so I think there was a little bit of a concern around the inherent infection risk with that approach, because you do have to give an anti-CD52 antibody along with the preparative regimen before giving that product.
Anything you want to add to that, Hans?
Yeah, I think that non-sort of BCMA targeting CAR T therapies are exciting. I think one of the advantages of targeting GPRC5D through a CAR T approach is that potentially the toxicity may be more limited because it's a one-time dose of GPRC5D targeting cells rather than continuous dosing with a GPRC5D targeting bispecific. So, and from a toxicity standpoint, it's something potentially that could be a better tolerated approach than continuous dosing.
So another question, Saad, from the chat room from Rebecca. This really gets an important concept that we want to talk about. Your cases get into it. She wants to know, is there any evidence supporting the idea of extending the time between injections, either to reduce the occurrence of toxicity or maintain patient well-being? And, particularly related to the issue of infections that we're seeing, Saad, any thoughts about what she's bringing up, extending a time between injection or even time-limited therapy as a way to avoid toxicity, particularly infections? Any thought about that, Saad?
No, certainly. So I had presented the teclistamab experience from the Majestic-1 study where, during that, phase 1 dose escalation, dose expansion study, after patients had achieved a sustained response, we would go to every, we were given the option to go to every Q2 or subsequently Q4 week dosing for patients. And what we saw, in that experience is a reduction in grade 3 infections by, almost half compared to patients who continued, to get weekly dosing after having, achieved that response. So, based on that information, in our clinical practice right now, once patients have gotten to an optimal, or response plateau, for a couple of cycles, we start giving them less frequent dosing to mitigate that infection risk.
Hans, any comments?
Yeah, I completely agree. And I think that, again, the less frequent dosing seen with several different bispecific clinical trials targeting BCMA, and of course, the less frequent dosing seen and the duration of response seen with longer follow-up with the Majestic-1 study and the Magnificent-3 study is quite encouraging. So I think this really speaks to the durability response after stopping therapy in hopes of restoring humoral immunity and basically mitigating the risk for infection.
Yeah, I find it really interesting how academic centers sort of modify their protocols as we go along, and we have a slide of what Memorial is doing in that respect in just a second. Let's talk a little bit about some of the data. Or not again, your presentations really go through it comprehensively. We were talking about the Majestic 1 trial, Saad. Maybe you can comment on that. You know, it's kind of interesting. We did a program last fall where we actually did video interviews with patients with myeloma. And I happened to interview a patient who'd been on teclistamab for a year and a half, having a great response, no toxicity, just sort of cruising along. And the day that I interviewed him was the day that teclistamab was approved. And I was just thinking, you know, it's different to be in clinical trials nowadays than in the past when you rarely benefit. And here was a patient who'd been benefiting for a year and a half before the drug was ever approved. Anything you want to say about these data? Obviously, the response rate is very impressive, Saad. Anything, you go through the trial in great detail in your presentation. Anything you want to say also about the issue of when you see CRS and how you manage it, Saad?
Certainly, I can comment on the CRS. So, you know, if you look at the CRS pattern, you know, it tends to happen in about 70-odd%, you know, of the patients. And if you look at the breakdown, you know, most of that happens with the first 2 step-up doses. And out of that 70-odd%, 50-odd% is grade 1 CRS. And what is grade 1 CRS? It's a fever, which can be managed with acetaminophen and supportive care. So I think that's the big advantage of bispecifics over CAR T cell therapies, especially, you know, in communities that do not have access to transplant cell therapy programs. So, you know, I think, you know, we need to do, you know, a good job in educating our colleagues in the community so that, you know, they can learn how to manage, you know, the bispecifics in real time.
And that really gets into management of CRS also, Hans. And I'm curious how you approach it, whether there are variations in it. Do you need to have tocilizumab available? What are some of the ways you think about managing CRS, Hans?
Yeah, so as Saad mentioned, you know, most CRS with bispecifics is grade 1, which is just a fever and treated with acetaminophen. I think one of the questions is the timing of tocilizumab administration when CRS does occur. And so I think there's been a general trend towards earlier usage of tocilizumab when CRS does occur to decrease the duration of CRS and potentially mitigate the recurrence of CRS. So there's some data showing that if giving tocilizumab for CRS could mitigate CRS for subsequent doses as well. And so certainly, you know, if a patient had grade 1 CRS lasting 2 to 3 days, I would definitely consider giving tocilizumab again to mitigate the duration. And then, you know, alternatively, in some situations where tocilizumab is not available, then, you know, considering giving dexamethasone and corticosteroids could be another option. But I think typically tocilizumab is the first choice in our practice. I would also mention that there's certainly been some investigation of tocilizumab prophylactically as a pretreatment prior to bispecific antibody therapy. And so there's some data now with cevostamab presented at ASH last year and some data with teclistamab presented at ASCO this past month, showing that the incidence of CRS does seem to be reduced by giving tocilizumab as a pre-medication, although there's still a number of grade 2 events seen despite the pre-administration tocilizumab. So I think really trying to figure out ways that we can really limit even the grade 2 events, which need supplemental oxygen and intravenous fluids potentially that require more hospital care is really important area of research in bispecific antibody therapy.
So much going on in myeloma and oncology. I was just thinking back. I feel like that interview with the patient was 2-3 years ago. It was last November when teclistamab was approved. And of course, the biggest question that I started hearing immediately, I was hearing it before it was approved, and Jack in the chat room has just asked that, can teclistamab be given by community oncologists without hospitalization? Before we kind of get to that, I'd like you to talk a little bit. This is really fascinating to me, how you at Memorial sort of adapted the way very quickly, in less than a year, how you're using teclistamab. Can you kind of go through that, Saad?
No, certainly. So, again, having been involved with teclistamab from cohort one, patient one, I was quite familiar with its clinical activity and CRS patterns. So when we did get the commercial approval, the one thing that we wanted to see is our real world patient population seeing the same safety pattern. And if we are, then let's figure out a way of giving patients the therapy in the outpatient setting. And so, if patients, manage the step-up dosing, without, high-grade CRS, then we started to institute the early discharge. And now, for patients who, are in a good performance status, do not have high burden of disease that would require hospitalization for other reasons, we've started to give all outpatient dosing. It's important to appreciate that, we still monitor these patients closely because we have an outpatient transplant set up so we can actually, see these patients at the drop of the hat. So we're doing this in the context of having the resources needed to monitor these patients in the outpatient setting.
So, and when or if community-based oncologists can use that kind of algorithm, who knows? But the fact that you're doing it, I think, is encouraging that maybe at some point this can be part of typical community practice. Hans, we talked a little bit about, I don't know if you call it Linvo, but maybe you can comment on this other BCMA bias. You made a couple of comments about it. You went through it in your talk. Anything else you want to say about this interesting agent?
Yeah, I think a couple of things about linvoseltamab that are a little bit more unique compared to the other bispecifics. One, it's given intravenously. And so there's pros and cons of giving bispecifics intravenously versus subcutaneous administration. I think one of the potential advantages of IV administration include the fact that the kinetics of CRS tend to occur earlier. So typically the median onset of CRS occurs within 24 hours, and the duration is also shorter as well. So this then lends to itself to have less hospitalization for CRS monitoring. And so for this linker MM1 study, only a 24-hour hospitalization was required for the first two step-up doses on week 1, day 1, and on week 2, day 1. The other aspect of this particular trial was that dosing frequency was reduced actually fairly early on in a response-adapted approach. And so in the 200 milligram cohort, by cycle number 6 or week 24, if a patient had a VGPR or better, then patient went to every 4-week dosing, which is more convenient for the patient. And I think finally, what also seemed interesting about this drug, which Saad alluded to earlier, is that the CRS rates numerically seem to be a little bit lower with linvoseltamab compared to the other bispecifics, although there is some caution about doing cross-trial comparisons in this regards, because again, they're small studies, but that signal is encouraging with this drug.
We also talk about elranatamab. That's why I do Elran, because it's not too good by the time I get to the end of it. But Hans, anything, again, we talked a little bit about it. Anything, here's some of the data. Anything else you want to add to this? I guess the sub-Q administration is an interesting aspect of this. Any thoughts about that, Hans?
Yeah, so the schedule of step-up dosing is pretty similar to teclistamab with the escalation done within the first week of ELRA administration on day 1, 4, and 7. I think one of the aspects of this particular trial that was a little different than teclistamab was that the hospitalization requirement, the built-in hospitalization requirement in the protocol was a bit less than that of teclistamab. So only a 40-hour hospitalization on the week 1, day 1 dose, and then only a 24-hour hospitalization on the second dose, no hospitalization thereafter. So it'll be interesting to see, this is currently under regulatory review of what the hospitalization requirements will indeed be for elranatamab, if it does get regulatory approval, if it will be potentially less than that of teclistamab, which from a practical standpoint, which would be nice to see.
Saad, any comments?
No, I don't have any additional comments. It appears
what about
that Hans and I are agreeing with most things.
Yeah, that's, well, you're on the same page. And we talked also about talquetamab. Any other comments about that, Hans?
Yeah, I think that the talquetamab data was very encouraging. You're seeing response rates of north of 70% in heavily pretreated patient populations. And I think what was also very encouraging is that we saw responses in patients with prior T-cell redirection. And so responses over 50% with patients with prior T-cell redirecting therapies, including those that target BCMA CAR-T and BCMA bispecifics. And so I think this really points to the fact that GPRC5D can be used following BCMA-targeted therapies in patients that progress on such therapies.
So I want to get into in a second, the survey we did of the faculty who have some very interesting outcomes. Before we do, both of you put together slides in your presentations. I'd like you to briefly comment on how you see the pros and cons of using these agents. Saad, here's your slide. Can you comment on the way you're sort of looking at this?
Yeah, so I think the first part of the pros really highlights the advantages for our community colleagues. I think the con part, the cons part is really the challenge we have, and we know these drugs work. Now let's try to figure out how to give them safely in the community, and that data will come from the real world. So that's where the con part comes in. We know that not every patient responds to bispecifics, and we're trying to figure out how to best maximize that response. And then we already talked about the infection risk. I think the other piece, obviously, is the logistic challenge for our community colleagues to manage patients in the outpatient, with the resources they have during that first month with the cytokine release syndrome and neurotoxicity. I think both CARs and bispecifics are going to have their place in the schema. It's just going to be probably different patient populations.
So this is your slide, and one of the things that you commented on when we were chatting that I think is really important to think about, Hans, from the point of view of sort of a disadvantage, is really the advantage of CAR T being quote one and done, and you're giving these patients some time off therapy. Any comments again on sort of how some of the key advantages and disadvantages you see that Saad didn't comment on, and particularly the disadvantage of having a continuous therapy as opposed to CAR T?
Yeah, I mean, I think we're seeing still unprecedented responses and depths of response for an off-the-shelf product with the bispecific therapies. And so as we get more real-world data on de-escalation of dosing and actually also fixed duration dosing, it may not necessarily be continuous for bispecifics and just one and done for the CAR T, but perhaps a hybrid approach with bispecifics where a patient perhaps will get a therapy for 6 to 12 months, get a very deep response, and potentially could stop therapy altogether. And so, perhaps it could be not a necessarily one and done, but several and done for bispecifics. Maybe that's an avenue of research for the future of trying to optimize the dosing frequency, and also mitigation of side effects down the road, like infection that we're all concerned about.
So actually I have another question in the chat room about eligibility for CAR T versus bispecifics, elderly patients, cardiac or pulmonary problems, how do they evaluate it, patients with Parkinson's. We'll get into that because we actually have some of those things are dealt with in the clinical investigator survey. So I want to just sort of go through this with you. This is our way of doing guidelines and consensuses, which is we ask people, what do they do in their practice, investigators, and they all say the same thing. We call it a consensus. If they say 3 or 4 different things, we go, well, it doesn't look like there's a consensus, but it gives you a little bit of granularity, at least, about how people are thinking about things. We know, of course, that, you individualize it based on the patient and many of the clinical scenarios. But here's a question we asked, which is, how would you compare anti-tumor activity of BCMA-targeted antibodies to a BCMA-targeted CAR T? Hans, looks like there's unanimity with thinking that CAR T has a greater anti-tumor activity. Of course, this is indirect comparisons, but what are some of the key numbers you think about on both sides of the equation, Hans? And why is it that everybody's saying BCMA CAR T, and this is really about cilta-cel?
Yeah, I think you hit the nail on the head with, I think a lot of people are talking about cilta-cel. At least that's what I was thinking about. I don't know if you're thinking about Saad, but I think the efficacy with cilta-cel is quite impressive. Longer follow-up, showing a median progression for 35 months is really unprecedented in patients with heavily pretreated triple-class refractory multiple myeloma. I would say when you look at the teclistamab and ide-cel data, I think if you look at the PFS and duration of response, is actually fairly similar. Is what my take is, and so I think when looking at ide-cel and teclistamab, again, more similar results. I think I'd also mention that, of course, with CAR T therapies, there's a bias probably towards taking less patients with really, really rapidly progressing disease because we're not going to actually be able to get a patient on a CAR T in that particular scenario. And so my feeling is that, there's probably more heavily pretreated, kinetically rapidly progressing disease in patients that enroll on bispecific trials than CAR T, which can also impact outcomes as well.
We asked a whole bunch of questions that were not shown tonight, Saad, but we asked a lot of questions about high risk, but I didn't show them because people view it kind of similarly in terms of activity. So is it your take in general with both bispecifics and CAR T that the responses seem like they're very similar in high risk and low risk patients?
Yes, I think, our general impression is that, we don't get the same bang for the buck, with either strategy for our, high risk and ultra high risk patients. And this is where, we need, newer approaches, maybe combining, bispecifics or, CARs that are dual targeting might be something, beneficial. Maybe some of the new cell mods might work better for, some high risk subsets. We need to, figure that out. It's still an area of unmet need.
So Kamal in the chat room has an interesting thought, Hans. Can you sandwich bispecific or can you use bispecific as bridging to CAR T therapy?
Yeah, that's a great question. I think a question that we talk about often amongst ourselves. I think that if using a bispecific as bridging, I would recommend or prefer to target with a different antigen than the CAR T is going to be targeting. So if it's a BCMA CAR T targeting with a GPRC5D targeting bispecific or vice versa. And then I think one other note to make is that, there is some theoretical concern about T cell collection right after a bispecific T cell antibody prior to CAR T. So if using a bispecific antibody as part of bridging, make sure to use it after the T cell collection until we get more data on that. Because again, T cell exhaustion, et cetera, could potentially lead to decreased T cell fitness and a less viable product.
Another question in the chat room, Saad, is we were going to get into this later, but while I remember it from the chat room, the question of where you see bispecifics landing. And obviously, people are thinking about it potentially being included as initial therapy. But the question was, do you see it more likely combined with induction therapy or more maybe part of maintenance with an MRD strategy?
I think it probably will be both, but we'll have to figure out the duration of treatment. I don't think that we are going to be, using bispecifics with the continuous therapy model in the frontline or maintenance setting. That's how we'd be able to mitigate the infection risk.
Hans, any thoughts about that?
Yeah, I think that all of the above will probably use some in the newly diagnosed upfront and some in the maintenance setting. But I think ultimately, when you use in this type of frontline setting, fixed duration, as Saad alluded to, I think will be the way to go in the future.
So, we tried to ask questions, some of them kind of very macro questions, but we know people ask these questions. They ask you all the time. So we decided to ask a bunch of you and see if you say the same thing. One thing, Saad, that we asked about was try to compare, and all this is indirect, but people just want to know kind of what your thoughts are in terms of BCMA targeted bispecifics versus some of the teclistamab versus the other BCMA bispecifics that are not currently approved. And it looks like, as you were alluding to before, people kind of view that the same. A couple of people thought that teclistamab might have more CRS toxicity. Do you think that's the case, Saad?
I think if you're thinking about, well, if you compare it with most of the other bispecifics, I think they're similar. I think I had shared that Linvo appears to have a lower, CRS rate. I think, Hans, you presented that data at ASCO, if I remember correctly. Please correct me if I'm wrong.
That's correct.
Yeah.
Yes.
So, I think it's difficult to, compare, the patient populations. We can comment is on the numeric nature of the CRS rates. But across the board, these are mostly grade 1. So the CRS that we really need to, worry about more is the grade 2 not turning into a grade 3. So I think that's the reason why I feel that it's somewhat similar, because the grade 2 CRS rate or higher is similar across each of these constructs.
So we were talking about CAR T and the fact that people are impressed by response rates, and we actually asked people, again, indirect comparison, how they compare cilta-cel to ida-cel, and certainly indirectly, cilta-cel seems to have terrific response rates. Hans, can you comment on why biologically or pharmacologically it's hypothesized that you see maybe greater effects, and also what about side effects and immune-related side effects?
Yeah, I think that the prevailing theory is that, because of the two BCMA binding domains on cilta-cel, this could lead to greater anti-tumor activity. Also, the cell dose with cilta-cel is quite lower than that of ida-cel, and so this is another aspect of the differences between cilta-cel and ida-cel. So ida-cel only has one BCMA binding domain. But in terms of toxicities, the kinetics of CRS onset and ICANS onset are different between the two products. And ida-cel typically has an earlier onset of CRS, whereas the median time to onset with cilta-cel is about 7 days or so, which can have implications on the practical administration of the treatments. But then we're also seeing some of the late neurotoxicity events with cilta-cel, both in the clinical trials, but also in practice as well, which is something we probably see a little bit less with ida-cel. So this is probably maybe one reason why in an older, frail patient, I might favor ida-cel over cilta-cel just from a toxicity standpoint in my own personal practice.
Saad, any comments on that, and also any updates in terms of the neurotoxicity? There's this Parkinsonian syndrome. I think it seems like there's less of it now, that it's being used more, but any updates on that?
Yeah, I think in clinical practice, in the real world, we haven't seen, a big signal, and part of that is, I think the cytoreduction that we utilize before patients get the CAR T cell therapies.
So this is an interesting, actually, again, I mentioned earlier in the chat room, somebody brought up this question of patients who you would consider eligible for bispecifics that you wouldn't send for CAR T. So we asked the faculty to give us examples, and you can see there's a bunch of older patients with comorbidities, 55-year-old patient with ejection fraction of 30%. Any comments on this, Hans? And also the question that was in the chat room about specifically cardiac and pulmonary, status and eligibility for CAR T versus bispecifics. You both had a couple of patients. One was on oxygen, another one with a heart disease. How do you think that went through, Hans?
Yeah, I think from this table right here, I think patients with rapidly progressing disease is where bispecifics make a lot more sense than CAR T, just because the time to apheresis, manufacture, and infuse cells is too long for a patient to practically get CAR T. I would say that, because there does seem to be a lower risk for higher grade CRS with bispecifics compared to CAR Ts, that's where I'd favor a bispecific in a frailer patient population, even with an EF of 35% or 40%. Just because, when you get to the grade 2 or grade 3 CRS, that's when you have to think about administering IV fluids. If they have cardiac failure, congestive heart failure, then they may not be able to tolerate some of the interventions to treat higher grade CRS. And so that's where I would say I'd favor the bispecifics.
So another thing we were curious about, we always are asking people, put aside regulatory and reimbursement issues, like theoretically right now, what do you want to do? And so, of course, one of the big questions here is sequencing and timing. So obviously these patients are going to need to be triple refractory, but then the question is, Saad, how much more therapy beyond initial therapy do they need before you start thinking about a bispecific antibody, and which antibody? Most people are sort of into the second relapse, but you bring up the issue of first relapse. Any thoughts, Saad?
Yeah, so again, taking that example of patients who can benefit from bispecifics with finite duration of treatment, and knowing that BCMA is not lost at subsequent relapses in most, majority of patients who get a BCMA-directed treatment, that's where the BCMA bispecific kind of makes sense. And I wrote teclistamab, but it could be any of the other ones as well.
So Hans, this is of course another huge question that people in practice want to know about. What comes first? Certainly there's, as we pointed out, or as you all pointed out, there are advantages to both. Why is it there's unanimity that CAR T in general for most patients should come first, Hans?
Yeah, so if access wasn't an issue, I think based on available data, we are seeing encouraging responses with bispecific therapy, either targeting BCMA or non-BCMA antigens after CAR T, so over 50% response rates, and some of the data with ELRA showing encouraging durations of response. Whereas we have somewhat limited data of CAR T after bispecific, but there is cohort C of CARTITUDE-2 published earlier this year, which did demonstrate a pretty significant diminishment of response rates, but also duration response of cilta-cel after prior BCMA targeted therapies, and some real world data from the US CAR T consortium, which also showed some diminished responses with CAR T after bispecifics. And so based on that data, I think many of us would prefer, if access was an issue, CAR T prior to bispecific.
Saad, any comments on that? And would you agree that either way, there's not going to be a plateau on the curve? And if so, why?
I think in the relapse situation, we really have not seen that plateau. So, as our myeloma colleague, Dr. Nina Shah used to say that we have plateau envy from our lymphoma colleagues, that we haven't seen that plateau. However, I think, once we start getting to dual targeting treatments, things may be different. So we just have to wait and see.
So we also asked whether or not we've talked before about using CAR T after bispecific in both ways, and the faculty has done it both ways and seen responses for that matter. We also asked Hans for people to describe the last patient they gave us bispecific to on or off protocol, and you can see most of these patients are older, but Dr. Nuka has a patient who's 49 who got actually interesting on the protocol, teclistamab, daratumumab, really interesting combination being studied. Any thoughts about the spectrum right now, Hans, of who's actually getting the bispecifics, and also the sequencing of theoretically that you expect to happen in the future when you have some of these other agents who are non-BCMA bispecifics available?
Yeah, I mean, I think that the great advantage of bispecific is that access, and so if you need an effective therapy for a patient, it's available right away. Actually, just to comment a little bit about this patient I described here, and actually, I just got some additional updated response data, and the patient after cycle 2 is now in a partial response. The response was upgraded. Is that this patient is an elderly patient and doesn't have a caregiver, and so didn't have a caregiver in the peri-CAR T period, and so she preferred to have a bispecific therapy. And so I think it's just nice that such an option was available for her. She's actually had prior bispecific targeting a different antigen, prior BCMA ADC therapy, and to see such a response is quite encouraging. I think in the overall sequencing of therapy, though, to your earlier question, I think we're all very excited about the CARTITUDE-4 data that was presented at ASCO and EHA this past month. And so if access and regulatory issues weren't a factor, I think many of us would consider perhaps giving a BCMA CAR T such as cilta-cel at first relapse, and then follow it with a non-BCMA targeting bispecific, or if they have a long duration of response, certainly a BCMA targeted bispecific could be an option as well. So potentially that could be one sequence strategy, but in reality, access will be the limiting factor. Access is the critical issue, and so I think overall, more patients are going to be treated with bispecifics nationally and globally just because of this sheer access issue. And these are very effective therapies with the bispecifics.
And speaking of access, I thought this was very interesting. We said, tell us about the last patient you gave CAR T therapy, and almost everybody refers to a patient who got cilta-cel. So I don't know, is access to both of these agents better than it was a year ago, Saad? Because I know there was a point where you all were just saying, just take whichever CAR T you can get.
Yeah, I think earlier this year, maybe 3 months ago, both the companies have increased their production capacity, and so it's very interesting. We're seeing more utilization of cilta-cel compared to ide-cel. Hans, I'm not sure what you're seeing in your clinical practice.
Yeah, I definitely think access has improved in the last year, but I think also, patients may have preferences on what they would want, in terms of their therapy, whether that be cilta-cel or ide-cel, and so we have discussions on the data that talks both efficacy and also safety, and so based on those discussions, patients may have one preference versus another after such discussions, because access is improving.
So a quick chat room question. Sounds like a real RTP type question from Kamal. Can you briefly summarize your take, Hans, on the median PFS and OS between BCMA CAR T versus BCMA bispecific at second relapse for patient? Talk about indirect comparison, but what is the indirect comparison? You're saying neither of them have plateaus. Indirectly, how would you compare, let's say, cilta-cel PFS and OS versus BCMA bispecific, teclistamab?
Yeah, we don't have mature data with BCMA bispecifics at first relapse compared to the, for instance, CARTITUDE-4 data. I would probably expect that the PFS and duration of response may be lower, but at the same time, patient selection can also play a role as well. So I think this is a limitation of doing cross-trial comparisons with bispecifics and CAR Ts, because it really comes down to patient selection and which types of patients go on the studies. So that's the caveat that I would give.
So we earlier were talking about the question everybody has: are bispecifics eventually going to be given by general medical oncologists? I'd say there's a consensus that yes, that's going to happen. Also, we asked about sequencing preference, and now that we're looking at these data, I'm thinking maybe it'd be different in people with prior CAR T. But in any event, this is the question we asked. Everybody said teclistamab before talquetamab, other than Dr. Krishan. We asked about a couple of trials that are ongoing, kind of what people thought they were going to show, and of course, Saad, prediction always has, the hazards, but we said, there's a trial looking at Dara RVD plus or minus teclistamab, and everybody's saying they think it's going to be more efficacious. I'm curious what you think the toxicity profile is going to be when you start adding in a bispecific on top of Dara RVD. Do we have toxicity safety data? I'm assuming we do. We have that trial.
Yeah, that data is not in public domain yet, but I'm hopeful that we'll have it either at ASH later this year or early next year, maybe at ASCO. I think again, the key would be not giving teclistamab the same way it was given in Majestic-1, but giving it in a different schedule and giving it for a defined period of time. I think that will mitigate the infection risk. even in the relapsed situation, the time to best response with teclistamab was about 3 odd months. And that's, I feel, Hans, that would be something similar with other BCMA bispecifics as well. And we see the same pattern with GPRC5D. So if you're seeing that in the relapse space, there's no reason to believe we won't see that in the front line.
So another trial that's very interesting, we were talking before about bispecific as part of maintenance. Hans, we were asking people how LRAN is going to compare to lenalidomide, which is actually being studied, and people are pretty optimistic about LRAN. What about the two together, Hans?
Yeah, so you're talking about combining a bispecific plus lenalidomide. Is that what you're asking, Neil? Yeah. So I think that'd be highly efficacious, especially converting patients with residual disease, MRD positive, MRD negative disease. And so I think that would be highly effective. I think, again, trying to deliver the bispecifics in a intelligent way, fixed duration, probably, for sustained MRD negativity and then stopping the therapy, I think would probably be the best way to mitigate risk for infection.
So we've been talking about some of the trials that are going on, the combinations. This one sounds really interesting. Saad, any thoughts about the idea of combining bispecific, in this case talquetamab, with anti-CD38 antibody, in this case daratumumab?
Yes, I think this speaks to the possibility that CD38 positive Tregs and Bregs may be downgrading some of the response and activity of the bispecific antibodies. So I think it's a good scientific question to ask, and we've seen some encouraging data with that, especially in the Q2-week dosing.
Well, this is my favorite. Teclistamab and talquetamab. Hans, any thoughts about that? The Redirect TT1 study.
Yeah, this was one of the most exciting abstracts at ASCO and EHA. And not only did you see an over 90% response rate, 96% to be exact, with the combination at the RP2D, but there were quite a few patients with true extramedullary soft tissue disease that was enrolled on the study, and the responses in extramedullary disease were quite impressive with the combination of both teclistamab and talquetamab. And so we're all looking forward to seeing more mature data with this approach with additional patients on the study.
Saad, any comments? And also, what do you see tolerability-wise when you combine the two? Is there more CRS? What happens?
So the CRS signal appears to be the same. The infection, at least at the current follow-up, isn't any higher than both of them put together. But, the depth of response is very impressive. So, I think, I'm looking forward to, seeing this, more data with this regimen. I know there are, expansion studies that are going to be looking at the high-risk subsets as well.
So, any comments? This is from your slide deck side on mechanism of resistance to bispecifics. Seems like there are multiple mechanisms. From your point of view, what are the major mechanisms of clinical resistance, Saad?
I think the nature of high-risk disease and proliferative nature of myeloma may get in the way. You're just not catching up with how quickly the disease is proliferating. But for the tumor microenvironment question of immune suppressor cells kind of downgrading the response, I think this is where the anti-CD38 combination story may actually play a role. For T cell functioning, there are clinical trials that are looking at checkpoint inhibition being combined with bispecifics, IMiDs and CELMoDs being combined. And, so it would be very interesting to see, how the immune profiling data looks like.
So we've gotten so many great questions from the chat room. I don't think we're going to get to your cases, but again, check out the presentations. A couple more really great questions coming in. So Hans, Bonnie wants to know what research is being done to predict who will respond to these agents. And David has a very interesting, I'm just going to read it because I'm not really necessarily sure I understand it, but I think I do. Will bispecific antibodies engaging another non-CD3 target when a particular subset of T cells, such as CD8 plus cytotoxic cells, find its role in myeloma treatment. So that, and how do you any way to predict benefit, Hans?
Yeah, I think there's a lot of work being done to try to predict response to bispecifics. There's a nice paper by Nazar Bayless published in Cancer Cell, I think earlier this year, which basically showed that the baseline T cell repertoire can help predict responses to bispecific T cell antibody-based therapy. So I think something in the future would be not necessarily profiling the myeloma cells, but profiling the immune effector cells and do basically immune profiling to see which immune effector cell subsets might be best suited for a particular bispecific antibody, which leads to the other question. Yes, there are other bispecific antibodies being developed, for instance, targeting CD16 on NK cells. And so there's a lot of excitement targeting other immune effector cells in myeloma beyond just CD3 on the T cell receptor.
So thank you so much, Hans and Saad. We all learned so much from you today. Audience, thank you for attending. Come on back Thursday, same time, same place. ER-positive metastatic breast cancer. We'll see what Dr. Bardia and Dr. Hamilton have to say, particularly about some of the data just presented at ASCO. Be safe, stay well, and have a great night. Thanks so much, Hans. Thanks, Saad.
Bye-bye.